Welcome, everyone. We're glad that you're joining us today to talk about treatment and prevention of tuberculosis. We're really delighted to welcome Dr. Connie Benson, a professor of medicine at the University of California, San Diego, who's going to be telling us where we are in 2024 as we're on the cusp of a new year. Please take a moment to fill out your demographic questions. They should be popping up as we speak. And so fill those out and we'll go ahead and log those as you do. Let's go ahead and go on to the next slide, but we're really delighted to have you here. Here are the financial relationships with companies within the last 2 years. They're listed here for your reference. And the next slide are specific to our presenter and to myself, as well as to the planners and reviewers. So please take a moment and review that. Here's the CME information. We're accredited as noted here, and the amount of credits is listed as 1.25. Please do avail yourself of that. And this is the range of different types of credits we offer for this particular activity. Next slide. Here are our supporters in terms of the program that we're about to embark on. So take a moment and read that, and let's go on to our next slide. Okay, a couple of logistics. We really welcome and are looking forward to your questions and comments. We'll have a number of, we're doing a poll right now, so you saw how that worked, and we'll display the responses to the poll questions. If you have a question, and we hope that you do, please use the Q&A button. We may not be able to get to all of them, but we'll certainly do our best to get to as many as possible. And please don't use the chat for the Q&A. We're going to be focused on the Q&A for that portion of the interactive session. Next slide. All right, with that, I'm really pleased to introduce my close colleague, Dr. Connie Benson, and I'm going to turn things over to her. She'll share her slides now. I'm looking forward to the talk ahead.
So, good day to all of you. We have participants from around the world, I believe, on our call today. So hopefully I can address many of your issues and concerns and questions related to treatment and prevention of tuberculosis in people with HIV. You've already heard or seen a slide with my financial relationships. These are the learning objectives for today, and you can read both of these at your leisure in your syllabus. So we're going to start with a pre-test couple of questions that I'd like to highlight for you, and you can go ahead and respond to these. Which of the following antiretroviral therapy regimens is safe and effective for use in people with HIV being treated for tuberculosis with a rifampin-based regimen? There are 5 choices here. One is a bictegravir-based regimen used once daily or twice daily. The next 2 are a dolutegravir-based regimen used once daily or twice daily. And the 5th choice is elvitegravir, cobicistat, FTC, and tenofovir once daily. So go ahead and select your choices here. We'll give you a few moments and then see a response shortly. Okay, we've got a pretty interesting display here. So it looks like the majority thought the once daily dolutegravir regimen or the twice daily dolutegravir regimen would be acceptable. I'm not going to give you the answer now. We'll be getting to that during the course of our lecture today. Let's move forward with our next pre-test question. Which of the following is a preferred regimen for the treatment of latent tuberculosis infection in people with HIV? And here only 4 choices: an INH regimen for 9 months, INH plus rifampin for 3 months, both of these with pyridoxine. The 4th is INH with rifapentine, weight-based dosing with pyridoxine for 1 month, given in a daily dose, and rifampin given daily for 4 months. Go ahead and make your choices here. Okay, so we've got a pretty good representation of responses here. So hopefully you'll figure out the right answer as we go through today's discussion. So I'm going to start off with a brief couple of introductory comments related to TB epidemiology and pathogenesis, and just briefly review these because they will set the stage for much of what I'm going to talk about related to treatment and prevention. So the WHO issues a global tuberculosis report every year, and the 2024 report details information from 2023. Worldwide, there were 10.8 million incident cases of TB and 1.25 million non-HIV TB deaths. And as of this year, the tuberculosis is the world's leading cause of death from any single infectious agent. You can see from the darker green here that the majority of these cases are in sub-Saharan Africa, in India and Southeast Asia, although we have representations from many parts of the globe. There's been a general decline in HIV TB incidence rates, particularly related to mortality, although in 2023 we still had 161,000 HIV and TB related deaths. The WHO, based on a modeling study that was published in 2016 and may be repeated in the next couple of years, estimates that 1/4 of the world's population, which is approximately 1.7 to 1.8 billion people, is infected with Mycobacterium tuberculosis. This obviously doesn't mean they all have active disease, but as you can see from this table, the representation of latent TB infection also depends on where you are in the world, with Europe and the Americas having the lowest rates, and Southeast Asia and Africa and the Western Pacific region having higher rates. In the United States, TB cases and incidence rates have also been tracked. And based on our peak number of TB cases, which occurred in 1992 with an incidence rate of 10.4 per 100,000 population, we now have a dramatic decline in that overall incidence rate, with 2023 seeing only 9,633 TB cases and an overall incidence rate in the US of 2.9 per 100,000. I do want to point out a little dip here. You can see as the trend had continued to move downward until 2020, there's been a gradual increase in reported cases since 2020. And here we are in 2023. And this represents what happened to tuberculosis incidence during the pandemic. This was replicated globally, although it wasn't quite so obvious in the WHO slides, but certainly is seen in the US. And the dramatic impact that the COVID-19 pandemic had on our ability to access treatment and prevention for tuberculosis was substantial. Just like globally, in the United States, there are pockets where tuberculosis incidence rates are higher, and these include California, Alaska, Hawaii, Texas, and New York being the big five in terms of overall incidence, with many of these places having about double or triple the overall rate of cases per 100,000 population. The majority of cases, however, in the US occur in persons who are not born in the US, meaning that they largely were people who immigrated to the US from areas with higher background endemic rates of tuberculosis and may have been infected before coming to the US. You can see we've got quite a low number or incidence rate among US-born persons compared to those who are non-US born, with the 15 cases per 100,000 population among those who are non-US born. And again, you can see this uptick over the 3 years that represent the COVID-19 pandemic. There are also differences in incidence rates by race and ethnicity in the US, again, representing Native Hawaiian or Pacific Islander, Asian, Hispanic or Latino, and Black or African American having higher incidence rates than Caucasian populations in the US. The percentage of cases that are HIV co-infected also differs slightly by origin of birth among persons with TB in the US. We've had a relatively steady state of the proportion with HIV co-infection, which ranges around 6% of all TB cases in the US, although slightly higher among those who are non-US born individuals. So just to digress for a moment, in 2023, the United Nations held a high-level meeting on TB to evaluate where we are in meeting our targets toward reaching TB elimination globally. And what you can see in these graphic bars on the right-hand side of your slide is where we are currently relative to where we hoped to be by 2025 in the upper part of the graph and by 2027 in the lower part. I know I'm only going to make a couple of points. The incidence rate and the number of TB deaths in this upper part of the slide are pretty far away from our 2025 goals. And the only area where we've made significant progress in the toward reaching our targets for TB elimination are in TB treatment coverage and coverage for tuberculosis preventive therapy in people living with HIV. So we're not meeting most of these goals and targets. And a lot of this is related to the impact that the COVID-19 pandemic had globally in short-term increases in TB incidence, deaths, and treatment coverage. And as that pandemic has waned, we still have a lot of work to do in eliminating TB globally. So let's turn now to the disease itself. Humans, as you know, are the primary natural reservoir for Mycobacterium tuberculosis, and human spread from person to person is accomplished via droplet nuclei and aerosols. The organisms can be expelled when an infectious person coughs, sneezes, speaks, or sings, and transmission occurs when another person inhales those droplet nuclei. And data have shown that as little as one infectious organism per inhalation can accomplish infection in the right setting. The pathogenesis of disease is based in part, or in large part, on the immune response to infection. After initial infection, the innate immune phase of disease takes over, with macrophages being the first line of defense. The alveolar macrophages ingest Mycobacterium tuberculosis, but the organism is capable of surviving within cellular phagosomes, so they aren't immediately killed until those macrophages are activated. Once the adaptive immune response occurs with cell-mediated immune response, most individuals will contain infection, will eradicate that infection through the formation of very strong calcified granulomata, and disease will not occur. And those who have active T-cell mediated immunity are those most likely to clear infection. The difference here probably has some to do not just with the host response, but also with MTB antigen load. If your antigen load is low and you have a very active cell-mediated immune response, you have infection arrest, healing, fibrosis of granulomata, and calcification. If the MTB antigen load is high, that can result in caseation necrosis within granulomata with central liquefaction, breakdown of those granulomata, and bronchial spread. And for those individuals who don't develop progressive disease, the risk of reactivation and dissemination can still occur. There was a very nice review article published in the New England Journal of Medicine this year that highlighted some of the important features of HIV-related tuberculosis. As you all are aware, cell-mediated immune response takes a little while to develop, usually does so within 3 to 8 weeks. If you have a normal CD4 T lymphocyte count, the granulomato's pathology is similar to those who are not HIV infected, as is pulmonary pathology, and the risk of extrapulmonary and disseminated disease is low. The key host cellular defenses, however, are dependent on active CD4 T cell surveillance and function, and the ability to elicit interferon gamma, IL-2, IL-12, TNF alpha, and other lymphokine responses that are responsible for macrophage activation and function. And with progressive decline in the CD4 count with untreated HIV to the point of advanced immunosuppression, the ability to contain MTB is markedly reduced. And that has consequences in both the pulmonary pathology that we see and the disease progression that we see and the risk for extrapulmonary infection. So let's go on and talk about diagnosis and treatment of latent TB first, because I think that's where most of us deal with our people with HIV infection. And I think as our thinking about MTB infection has grown and evolved over the last several decades, there are several general principles to keep in mind. There is often one of two outcomes that occur following a TB exposure to an infectious person. About 30% of otherwise healthy adults may become infected, and I include that in quotes. However, most of these will clear the organism with no subsequent evidence of infection and go on to develop latent TB infection. About 5% of those who do become infected will develop some evidence of TB disease within the first 2 years most often. And there's a spectrum of what we consider TB disease that we recognize now. That can be clinically quiescent disease, early reactivation following clinically quiescent disease, subclinical disease where you have positive cultures but no symptoms, and then moving on to progressive disease. And a lot of this does depend on the mycobacterial load at the time infection occurs. We currently define latent TB infection as the complete absence of signs, symptoms, or evidence of active disease, but in the presence of a positive test for TB infection. And that may be a tuberculin skin test or more recently an interferon gamma release assay as the preferred diagnostic test. So what is the risk of developing TB disease in people with HIV? In immunocompetent adults, I've already reviewed this, 5% may go on to develop some evidence of TB disease within the first 2 years after index exposure, but have a 10 to 12% lifetime risk of reactivation thereafter. In people with HIV, that risk is dramatically increased. There's a 30 to 40% risk of developing TB disease in 2 years after an index exposure. That's highest within those first 2 years and decreases over time in low burden settings, but may not decrease substantially in high burden settings. And that translates to about a 3 to 16% risk per year thereafter for the lifetime of an individual with HIV. With the exception of those being treated with effective ART. And that's 3 to 12 times greater for people with untreated HIV than for those without HIV. Obviously, effective antiretroviral therapy can modify that risk. It still doesn't return the risk to that of those without HIV infection, although it does decrease the risk of moving on to progressive disease, certainly with ART and with treatment for latent TB infection. And both ART or treatment for latent TB infection decreases the risk of death and severe illness in people with HIV. So I've already alluded to the diagnostic tests for latent TB infection. You're all very familiar with the standard men-2 tuberculin skin test. And here in the box are the thresholds for what are considered positive for induration in terms of millimeters, with HIV being associated with a greater than or equal to 5 millimeters of induration as a positive test in that setting. The preferred test now, however, is interferon gamma release assays. This is a blood test that is based on an ELISA assay evaluating the release of interferon gamma by T lymphocytes in response to MTB-specific proteins in vitro. And operational characteristics of these tests have been evaluated extensively in people living with HIV. And this is just one study that was recently published in 2021 with a large CDC study that was done globally, and evaluated the tuberculin skin test, a quantiferon golden tube, the standard golden tube, which now has been updated, and the T-spot TB test, which is another interferon gamma release assay. And what you can see is that the sensitivity was highest in the quantiferon golden tube, specificity was highest in the T-spot TB, but specificity was comparable across all three different assays. And where they differed most often was in the positive predictive value of the test. The negative predictive value was equivalent across all three tests. And of note, quantiferon tests or interferon gamma release assays do not cross-react in people who've been vaccinated for BCG, and they are not boosted. So you don't have to worry about boosting in the setting of use of interferon gamma release assays. Turnaround time is similar in the laboratory for the interferon gamma release assays. And as you know, it takes 48 to 72 hours to see induration with a tuberculin skin test. So what is the guidance for testing people with HIV for latent tuberculosis infection? Current guidelines published by the NIH, CDC, IDSA guidelines panel suggests that all people with HIV should be tested for LTBI at the time of their diagnosis. Positive test for LTBI should include an evaluation for active TB disease. If your original test was done at a point where the CD4 T cell count was less than 200, and was negative, those individuals should be retested once they're started on antiretroviral therapy and their CD4 T cell count increases to above 200. And just keeping in mind that a negative test does not rule out active TB disease. Annual testing is only recommended for those who are at ongoing high risk of exposure. And at this point in time, obviously, this means individuals who are close contacts of patients with infectious TB, if they're born or living or formerly lived in a high TB burden country, or if they are living or working in high-risk congregate settings. And obviously, some of the other risks due to immune compromise also apply to people with HIV co-infection. So what are the recommendations for who should be treated for latent tuberculosis infection? For people with HIV, any positive screening test, regardless of BCG status, and in those individuals have no evidence of active TB disease and no prior history of treatment for active TB or latent TB infection. There is one caveat for people with HIV. If they have been a close contact of an infectious person, regardless of their screening test result or their CD4 T cell count, it's currently recommended that they should be treated for LTB, for latent TB infection. And why is that? This is a very nice study done from a global evaluation of household contacts from 247 households of individuals who had a household contact with an infectious person. And in this study, the 1-year cumulative risk of latent infection was about 22%. The 1-year cumulative risk of TB disease was 2.3%, but the TB disease relative risk among children less than 5 years of age or people living with HIV was 11.5 and 10-point-fold higher than these 1-year cumulative risks, regardless of whether they had a positive screening test and regardless of their CD4 T cell count. So the treatment regimens that are currently recommended for latent TB infection are listed on this slide, and there are preferred and alternative regimens. There are 2 preferred regimens, both of which have been studied extensively. The first is a combination of isoniazid with rifapentine. The dose is indicated here, and including vitamin B6 or pyridoxine, each given once weekly for 12 weeks. And the second preferred regimen is isoniazid plus rifampin plus pyridoxine given daily for 3 months, or 3HR. This is also an acceptable regimen for pregnant people with HIV. The alternatives are what we used to consider the standard of care, isoniazid given for 6 to 9 months together with pyridoxine. And other alternatives include daily rifampin for 4 months, or one daily isoniazid and rifapentine in these doses together with pyridoxine given daily for 4 weeks. For people exposed to drug-resistant TB, there is a new recommendation for use of levofloxacin, and I'll highlight that in just a moment. I do want to point out there's a couple of controversies related to, in particular, the 1HP alternative regimen. This is the largest single study of preventive therapy in people living with HIV. It enrolled 3,000 people with HIV in 10 different countries and followed them for 3.3 years. And in the US, this is only indicated as an alternative regimen rather than a preferred regimen, despite the fact that it was equivalent to 9 months of isoniazid with greater treatment completion rates and lower rates or comparable rates of adverse events. And the reason that it's currently listed as an alternative regimen is that was a relatively small number of individuals in the study, comparatively speaking, who actually had a positive interferon gamma release or tuberculin skin test, representing about a quarter of the study participants. And while that's significant, one should note that the rest of individuals enrolled in that study were enrolled in very high background endemic countries with rates of tuberculosis greater than 60 per 100,000 population, and at very high risk for developing TB, at risks that were equivalent to those with a positive tuberculin or interferon gamma release tests. So what about antiretroviral therapy? If you're going to be prescribing latent TB infection, there are a number of caveats with what you can do with ART, and it depends obviously on the regimen that you choose for treating LTBI. There is a published study in clinical infectious disease that evaluated the 1HP regimen, daily isoniazid and rifapentine for 4 weeks, and looked at twice daily dolutegravir during 1HP, and the trough concentrations were found to be actually greater than what one would see with a standard dose of dolutegravir once daily when you're not receiving 1HP. So good evidence that twice daily dolutegravir would achieve adequate concentrations during 1HP. There's also been a clinical trial that was presented at CROI this year, a phase 1/2 randomized clinical trial comparing the 3HP preferred regimen with 6 months of isoniazid in treatment-naive people with HIV being treated with dolutegravir once daily. And despite a 72% induction of dolutegravir clearance, the week 8 viral load suppression and the week 12 and viral load suppressions were comparable for both the 3HP and the 6 months of isoniazid respectively. And so this has led to a recommendation that dolutegravir be administered once daily during 3HP treatment and twice daily during 1HP treatment, if those are the choices that you elect to choose. There has also been evaluation of bictegravir with TAF and FTC during a 1HP regimen. And although about 92% of individuals were virally suppressed on day 15 of that 1HP regimen, and all were suppressed at month 3 and 6. This was a relatively small study with longer-term follow-up not available, and so bictegravir is not currently one of the preferred regimens in treating latent tuberculosis infection. So these are the studies that I alluded to and that have recently been released in prevention of drug-resistant TB. And I'm not going to go into great detail. TB CHAMP was performed in children. up to age 17, and the VQuin trial was a phase 3 randomized controlled trial in adults, both of which evaluated levofloxacin in appropriate doses for the population compared with placebo in people who were exposed to MDR-TB as a household contact. And what you can see is that there was a 45 to 55% decline in risk of MDR-TB occurring with levofloxacin, and it was safe and well tolerated and is now in WHO guidance. There is an ACTG clinical trial and that is being conducted by both the ACTG and the IMPACT network that is evaluating delamidid compared with isoniazid after a household exposure to MDR-TB. That study is ongoing, and we hope to see results in the next couple of years. What about vaccine prevention of active TB? There's been a lot of work for vaccine development, both in individuals with latent TB infection and individuals who are exposed to TB. This is just one example of a study that was a phase 2b randomized clinical trial in HIV seronegative adults with latent TB infection. They were randomized to receive one of 2 doses of M72-AS01E or placebo, given 1 month apart. The primary endpoint was bacteriologically confirmed active pulmonary TB, and this particular vaccine actually decreased the incidence of tuberculosis in this group by about 54%, with adverse event rates primarily being injection site reactions. And although review of TB vaccines is beyond the scope of today's discussion, this is just a representative slide showing you that there's a fairly large number of vaccines in the pipeline for development, with a number of these that have reached phase 3 clinical trials, including the one I just highlighted, as well as the MTB-vac, and several of these others are taking advantage of some of the messenger mRNA vaccines that have been popular following the success with COVID vaccines. So let's now go on to clinical disease with tuberculosis in people with HIV. Many of you are very familiar with the clinical manifestations of TB disease. And as I alluded to earlier, those with normal CD4 counts on antiretroviral therapy present with pulmonary TB that's similar to those in HIV uninfected individuals, with subacute onset of fevers, night sweats, fatigue, weight loss, productive cough and chest pain, upper lobe involvement with cavitary disease. However, as immunosuppression advances, there may be more localized or progressive lower lobe infiltrations or non-cavitating disease or miliary or disseminated disease. And a good proportion of people with HIV may actually present with positive sputum cultures and a normal chest X-ray, at least initially. This is just a representation of what miliary TB looks like on a chest X-ray, with each of these individual reticulonodular infiltrates about the size of what is a millet seed. I don't know about you, but I've never seen a millet seed, but you can imagine what that small size looks like. Extrapulmonary tuberculosis is common in people with HIV, represents about 20% of our cases, although with more advanced immunosuppression, that number or percentage may rise to as high as 40%, with the most common being TB meningitis, osteomyelitis, as represented on the slide here, with the classic presentation of Pott's disease in the vertebral body here, and abdominal and renal TB. Diagnosis of tuberculosis disease, I could do a whole hour talk just on new diagnostics for tuberculosis disease, but let's suffice it to say that we have numerous diagnostic tools at our disposal now. The gold standards have been sputum acid fast bacilli smears, or AFB smears. These are positive in only about 50% of people with HIV presenting with TB. Culture of sputum or any infected tissue or body fluid usually requires either a solid media culture In the old days, this is what a slant of LJ or Middlebrook media might look like, but more often we use midget or liquid culture, and this is a BACTEC machine here. Rapid tests have become the standard in many parts of the globe now with nucleic acid amplification, urine lipoarabinomannan, which is a component of Mycobacterium tuberculosis cell wall, conventional culture-based drug susceptibility testing, which gives us a phenotypic DST result, or rapid drug susceptibility testing with line probe assays that give us a genotypic test result. And then, of course, molecular testing to detect genome or genomic mutations with whole genome sequencing. So a lot of new diagnostic tests available to us. One more comment here. While urine LAM tests are a rapid test that are available and have been shown in clinical trials to be more sensitive in people with HIV, these are not available in the United States. They're more often used in hospitalized patients in resource-constrained settings as an adjunct to TB diagnostics. So the two most frequently used rapid tests I just want to highlight for a moment. Nucleic acid amplification testing is the rapid identification of DNA or RNA obtained from specimens and amplified by PCR. This has about a 2-hour turnaround time when you're using a gene expert MTB RIF or the Ultra test. The Ultra test is a next generation gene expert test and can detect both INH and rifampin resistance and has higher sensitivity and specificity than the previous version of the gene expert test. Line probe assays can both detect MTB and can detect drug resistance as well. And these are amplified DNA or RNA tests that are reverse hybridized onto nitrocellulose strips using MTB-specific probes. And the second and third generation LPAs can detect resistance not only to INH and rifampin, but also to the fluoroquinolones, some of the aminoglycosides, and some of the other second-line TB drugs. So these are major advances in rapid diagnostic testing. Just another point about the Expert Ultra test, and this has been evaluated in people with HIV and people with paucibacillary TB. And I've highlighted in the boxed portion of the slide here that the Ultra is more sensitive in smear-negative individuals with paucibacillary TB and more sensitive in people with HIV than the standard Gene Expert test. Sensitivity and specificity is comparable with other populations. I'm not going to say a lot about whole genome sequencing, but just to indicate that the ascent of whole genome sequencing is on its way into our armamentarium more rapidly than we might have predicted. It can be used both to predict susceptibility profiles. You can detect INH, rifampin, ethambutol, and pyrazinamide resistance with high sensitivity and specificity. And there have been studies that are starting to look at using sequencing assays in the clinical management of tuberculosis. Obviously, this entails a lot more work and may be more expensive and probably not useful in a lot of resource-limited settings, but you may see data about this in the near future. So let's move on to general principles of TB treatment. Treatment should be guided by exposure history and drug susceptibility testing. Obviously, we need to use multiple active drugs, at least initially, and current recommendations that you use 3 to 4 active drugs administered simultaneously in an effort to overcome the high volume of replicating organisms in lung cavities and the random mutations that confer resistance, as indicated here, for INH and rifampin. And organisms within granulomas or the intracellular environment may also have intermittent bursts of replicative activity and also undergo random mutation, another reason for using multiple drugs. It's also recommended that directly observed therapy be accomplished when that's feasible, although with some of our better regimens now, we are getting comparable rates of treatment completion without necessarily requiring directly observed therapy. So these are the current recommendations in the US for treatment of drug-susceptible tuberculosis. Most of the recommendations I'm giving here, I should have highlighted this earlier, are based on US recommendations. And remember, the US is a low burden setting. Isoniazid, rifampin or rifabutin, pyrazinamide, and ethambutol with vitamin B6 given daily for 8 weeks, followed by the continuation phase of isoniazid and rifampin or rifabutin given daily for 18 weeks continues to be the preferred regimen for treatment of drug-susceptible tuberculosis. However, there is a caveat, and that has to do with the recent data of alternative shorter course regimens for treatment of tuberculosis. And this is recommended for people with HIV who are on an efavirenz-based ART regimen, and I'll get to the reason for that in a moment, but not recommended for those with extrapulmonary TB. And this alternative regimen is isoniazid, rifapentine, moxifloxacin, and pyrazinamide given daily for 8 weeks, and then INH, rifapentine, and moxifloxacin given daily for an additional 9 weeks. The duration of treatment should be extended for those who do not culture convert after 8 weeks of treatment, or if they have severe cavitary disease or disseminated extrapulmonary disease. And just one other caveat, intermittent regimens of twice weekly or 3 times weekly are not recommended, particularly for people with HIV, because they are associated with higher rates of drug failure and relapse. So what is this short course TB treatment? You all probably recognize this New England Journal of Medicine article and its follow-up in Clinical Infectious Disease in 2022, looking at this same regimen in people with HIV. And this was an open-label phase 3 trial done in more than 2,500 individuals with newly diagnosed pulmonary TB from 13 different countries, and compared the standard of care with isoniazid, rifampin, pyrazinamide, and ethambutol with 2 4-month regimens of rifapentine replacing rifampin in one of the regimens, and the second 4-month regimen with rifapentine and moxifloxacin replacing rifampin and ethambutol in the regimen. And suffice it to say that after substantial duration of follow-up and noting similar results in the people with HIV who were enrolled in the study on efavirenz-based antiretroviral therapy, the rifapentine moxifloxacin regimen given for 4 months was equivalent or non-inferior to the 6-month standard of care regimen. And this is why this is now an alternative for treatment of tuberculosis in individuals both with and without HIV infection. In looking at this study, there was also an attempt to analyze some of the risk factors for outcomes. And this just highlights some of the work that was done there, showing that the drivers of poor outcomes in the study of rifapentine and moxifloxacin in that arm were low rifapentine exposure, higher baseline disease severity as defined by extent of disease on chest X-ray, and the cycle threshold for the gene expert, with a low cycle threshold being the threshold that was evaluated. And you can see that all of the regimens were comparable in terms of a success when they, in the easier to treat population with none of these high risk factors. But as you got to higher risk factor involvement, there were stark differences. And there's now a randomized clinical trial being proposed in the ACTG to stratify and assign people to treatment regimens based on those risk factors. The other recent study that was of note about short course treatment for rifampin susceptible or drug susceptible TB was the Truncate TB study. And this was an interesting study design, an adaptive study design that was open label, randomized, comparing a standard of care regimen with 4 different strategy groups given for only 8 weeks of treatment. with the caveat that treatment could be extended if clinical disease persisted, if cultures remained positive, or if there was evidence for early treatment for relapse. Each of these 4 strategy groups included either a high-dose rifampin together with linezolid or clofazimine, or bedaquiline or rifapentine given with linezolid, and each also received INH-PZA or ethambutol. So 5 drug regimens in the 4 strategy groups. The primary outcome is listed here. In the standard of care arm, 98% of individuals completed treatment, only 3% required retreatment. And as you can see in the 4 strategy groups, there was substantial ability to shorten the duration of treatment to 85 to 106 days, with the best strategy group being the 8-week regimen of INH, PZA, ethambutol given with bedaquiline and linezolid. And this was non-inferior to the standard of care arm. So we haven't yet seen this emerge into treatment recommendations, but we will shortly. So just like with LTBI, there are caveats about antiretroviral therapy during treatment for TB disease. All people with HIV and TB disease should receive ART regardless of their CD4 count. It's recommended that TB treatment start first and then start with ART. And although current recommendations suggest that most people should start therapy within the first 2 to 8 weeks of TB treatment, most experts now recommend within 2 weeks for all, because our ART regimens are now much better tolerated with fewer drug-drug interactions. And this is particularly important for those with low CD4 counts. An exception here is for TB meningitis, and it's currently recommended that you start ART when there is clinical and microbiologic evidence of improvement, and after at least 2 weeks of TB treatment to reduce the risk of IRIS. Adjunctive corticosteroid therapy continues to be recommended for people with HIV and TB meningitis, despite the fact that there was at least 1 randomized clinical trial that showed no mortality benefit. That trial had several caveats that current treatment guidelines panels have suggested minimize the impact of that particular clinical trial. And we may get to more of this in the question and answer. These are the recommended regimens for use in TB treatment containing a rifampin-based regimen. So dolutegravir antiretroviral therapy should be given twice daily for active tuberculosis treatment with a rifamycin-containing regimen, or efavirenz given 600 milligrams daily with 2 nucleoside analogs. You can use a ritonavir-boosted protease inhibitor, but in that situation, replacing rifampin with rifabutin is recommended. But specifically, darunavir boosted with ritonavir or cobicistat should not be used. That has been associated with higher rates of severe hepatic toxicity. So that is one PI that should not be used with a rifampin-based treatment regimen. And if you use dolutegravir given twice daily during the course of TB treatment, that should be continued for about 2 weeks after completion of TB treatment so that the rifampin induction has faded. Antiretrovirals not recommended when rifamycins are included in the regimen. I've already highlighted a couple of these, but any PI with cobicistat, bictegravir, and there's a caveat here, elvitegravir with cobicistat, etravirine with boosted PIs, and lenacapavir, because we have no data on those. And lastly, 2 drug regimens are not recommended currently due to inadequate data about their effectiveness. There have been some attempts to look at dosing with rifampin-based TB treatment of various antiretroviral drugs, and this first study was published back in 2020 and is the basis for using twice-daily dolutegravir ART when compared to efavirenz-based ART. At week 48, the viral suppression rate was 75% for dolutegravir and 82% for efavirenz. However, the TB outcomes were the same, and these curves are overlapping and not statistically significantly different, although the slightly lower non-response rate with dolutegravir was driven more by loss to follow-up and not by virologic failure. There was a study presented this year at CROI that also evaluated twice-daily bictegravir-based regimens with twice-daily dolutegravir and once-daily 3TC and tenofovir in people who had received rifampin-based TB treatment. And in that study, 97% of individuals in both arms were fully suppressed virologically at week 24, with TB outcomes the same, but a relatively small number of individuals given or received bictegravir-based therapy in this regimen, and long-term follow-up is not available from other larger studies, so it's still not one of the recommended regimens. As you know, paradoxical reactions to antituberculous therapy can occur even in people without HIV infection, and mimics the immune reconstitution inflammatory syndrome that we see in people with HIV, and represents a transient worsening of signs and symptoms of TB or radiologic deterioration after starting antiretroviral therapy. This can occur with existing TB already diagnosed, or you can unmask some subclinical TB in the setting of ART. This generally occurs in the first 4 to 8 weeks after starting antiretroviral therapy, and individuals can be, if they are at high risk for developing IRIS, there has been at least one randomized clinical trial, largely done outside of the US, looking at preemptive prednisone given for 2 weeks or 4 weeks, which can reduce the risk of IRIS and mitigate the morbidity associated with IRIS. If IRIS does occur, treatment is available, and for mild to moderate symptoms, non-steroidal anti-inflammatory drugs or supportive therapy is appropriate, but for more severe IRIS cases, prednisone should be given and tapered over a 4-week period of time based on the individual patient's symptoms, although many of you probably have had some experience that there can be a recurrence of IRIS during that taper and or a delayed response, so that a more gradual taper of prednisone may be required. So the last part of the talk, I'm just going to highlight a few points about drug-resistant TB. This is based on the WHO Global Tuberculosis Report, again, showing that about 3% of new and 16% of previously treated cases have multi-drug or rifampin resistance in 2023 for about 400,000 incident cases. And again, Southeast Asia, India, and Sub-Saharan Africa are the areas where we see the highest incidence of drug-resistant TB. This has been gradually declining, but over the course of the pandemic, this leveled off, like many things we've seen with TB during the pandemic. And this represents our experience here in the US. We've had really a relatively steady state of percentage of people with multi-drug resistant tuberculosis in people who've had no prior TB. And those with previous TB, also a pretty much steady state percentage here, but relatively low, and with no more than 1.1 to or 0.5 to 1.5% of cases. Why is it important? Because success rates for TB treatment with drug-resistant TB have been traditionally much worse than for individuals who have drug-susceptible TB. Treatment success rates are also lower for people with HIV compared to those without HIV, and so by comparison, people with drug-resistant TB who have HIV also have lower treatment success rates. So what are recommendations for treatment of drug-resistant TB? And this is probably the area of tuberculosis research that has changed most dramatically in the last decade. Current recommendations are to use in individuals who have monoresistance to isoniazid, substituting moxifloxacin or levofloxacin for isoniazid with the traditional doses of rifampin or rifabutin, ethambutol, and pyrazinamide for a 6-month duration. For those who have resistance to rifamycins or multidrug resistant tuberculosis, there is a new preferred regimen using pretomanid, linezolid, moxifloxacin, and bedaquiline for 6 months of treatment. An alternative for individuals who can't access or tolerate that regimen would be individualized therapy based on drug susceptibility testing to include at least 5 active drugs. And this recommendation is based on WHO recently released recommendations for a 9 to 12 month all oral regimen for treatment of MDR-TB, with all 3 of these drugs from Group A combined with at least 1 from Group B and 1 from Group C, or 1 or 2 from Group B and 1 or 2 from Group C, depending on drug susceptibility testing, as oral regimens. It's no longer recommended that an aminoglycoside be included in the regimen unless there is resistance to the extent that you can only achieve active drugs with an aminoglycoside. What is the basis for this new preferred therapy of what's often now referred to as BPALM or BPALM? The original trial was the NICS-TB study, which was a single-arm open-label study, followed thereon by the XENIX study, which is a randomized clinical trial that compared bedaquiline, pretomanid, and linezolid given in different doses in the treatment of drug-resistant TB. And as you can see, very high rates of favorable TB outcomes were seen with the BPAL regimen, with the highest being seen with linezolid dosing that was continued for the full course of therapy. And what's emerged from this trial was a 600 milligram linezolid dose for 26 weeks. TB Practical is a more recent study that compared standard of care for drug-resistant TB with this BPAL regimen, or BPAL plus clofazimine, or BPAL plus moxifloxacin. And the best performance in this study was with the BPAL moxifloxacin regimen, which had only a 12% unfavorable rate compared to a 41% unfavorable rate of with standard of care at 72 weeks, as indicated over here. So this is now the preferred regimen for initiation of treatment for drug-resistant TB. There are, like vaccines for TB, a whole host of new TB drugs that are in development. And this is just a single slide highlighting the global TB drug development pipeline. As you can see, most of these red drugs are over here in phase 2 development. Only one has made it through to phase 3 development. And most of our new regimens are using some of these other drugs that have already received regulatory market approvals. But it has been this explosion of new drug development in TB that has resulted in a much improved ability to treat drug-resistant TB. And many of these drugs are now also being evaluated in drug-susceptible TB and in regimens that are being referred to as pan-susceptible, meaning all TB comers with some of these regimens. So in summary and conclusion, I'd just like to highlight that TB is the most common infectious cause of death globally. Post-TB lung disease, which I didn't highlight in any detail, is increasingly recognized. Despite having successful treatment of tuberculosis, this highlights the fact that we'd like to not have to treat tuberculosis. We'd like to prevent it, because in at least one recent study, up to 40% of individuals had evidence of post-treatment lung disease based on spirometry and radiographic changes, and is increasingly recognized as a key morbidity in people who recover from TB treatment. People with HIV are at higher risk of TB infection and disease, even in the presence of active antiretroviral therapy, although effective ART reduces but does not eliminate that risk, and it does improve outcomes of treated disease. The approaches to screening, diagnosis, prevention, and treatment of TB disease continues to improve, especially for drug-resistant TB. We have a robust pipeline of new anti-TB drugs, including work being done on novel long-acting agents, and there are increasing efforts aimed at vaccine development. But all of this requires an ongoing need for global political, financial, and public health efforts to eliminate tuberculosis and enable us to reach those targets that I highlighted at the beginning of the talk. So I think we'll go on to, based on the what we covered today, to look at our pretest question again. Which of the following ART regimens is safe and effective for use in people with HIV being treated with a rifampin-based TB regimen? And again, we have 2 bictegravir regimens, 2 dolutegravir regimens, and elbictegravir regimen. So based on what I talked with you about today, which of these would be a recommended regimen for treatment with rifampin-based TB treatment? I'll give you a moment to respond here.
Currently, the dolutegravir is twice a day, and the TDF-FTC is that once a day for choice D. Is that right?
I'm sorry, what's your question, Raj?
I was just double checking that choice D is dolutegravir twice a day with TDF-FTC, that portion
Yes.
given once a day. Is that right?
Yes, there's a once daily dolutegravir or a twice daily dolutegravir.
Perfect. Thank you.
Okay, looks like we have a big improvement for treatment of active TB with dolutegravir twice daily if you're going to use a rifampin-based regimen. Let's look at post-test question number 2. Oh, I guess I should review this. This is just showing that the correct answer is the twice daily dolutegravir regimen. I showed you some of the data from those studies during the talk. Although bictegravir twice daily could potentially be used, it's not currently recommended due to insufficient longer-term data in people with HIV. Elbictegravir and cobicistat should not be used. So post-test question number 2, this is for latent TB infection. Which of the following is a preferred regimen for treatment of LTBI? And here we have isoniazid given for 9 months with pyridoxine, isoniazid and rifampin done daily for 3 months with pyridoxine, INH and rifapentine with pyridoxine given once a month or daily for 1 month, and then daily rifampin for 4 months. And the purpose of this question was primarily to highlight the alternative regimens for tuberculosis treatment. So, and this is the correct answer: INH, rifampin, and pyridoxine given daily for 3 months. And 1HP is an alternative regimen, although that's inside the United States. So these are the explanations for many of these. I'll just highlight for 3HR, or the 3-month regimen, as a preferred regimen. There were 4 randomized clinical trials and a recent meta-analysis, all of which showed, this is dating back to 1992, most of these done in people without HIV, but all showed comparable prevention rates and higher completion rates and lower adverse event rates when compared to 6 to 9 months of daily isoniazid. And although this 3HR regimen was not directly evaluated in a large randomized clinical trial in people with HIV, it remains one of the preferred regimens because of this large basis of other randomized clinical trials. Other regimens listed in this post-test question are all alternatives to this preferred regimen. And so I think we're ready for Q&A now, Raj, when
Great. Perfect. That was terrific, right on time, and we have just under 10 minutes for questions. There's a good number, so I'll go through them and ask maybe for fairly quick responses so we can get through a number of them. Two comments though. John Brooks comments that a millet seed is the size of a buckshot, or I guess a shot, lead shot used in shotguns. And then good to know, John. And then
only
Neela,
somebody from Georgia would know the answer. Know that.
and Neela Goswami comments that if you have a patient with MDR TB, CDC has a TB lab that can help with bedaquiline and pertonemin, the nasal susceptibilities. So the first question is, can you comment on we all use vitamin B6 pyridoxine with INH. Is there any concern about giving too much pyridoxine where it might interfere with the activity of the INH and latent TB therapy when we give pyridoxine?
I think it's a theoretical possibility, but the doses that we're recommending, 25 to 50 milligrams a day, should not interfere with isoniazid.
I looked this up once. It turns out isoniazid makes you urinate out pyridoxine, and so what we're doing is we're just replacing that kind of the loss in the urine. So this is a very common question. I'm interested in your thoughts on a person who has inconsistent interferon gamma release assays in terms of treating them for latent TB. It's not uncommon to have someone have a positive IGRA and then later on a negative IGRA. How do you handle that?
Well, theoretically, you shouldn't serorevert. And so usually that is related to interference with the interferon gamma release assay itself. We see that often with healthcare workers who, as you know, the CDC, and maybe John could comment on this too, if he would like, no longer recommends annual testing for healthcare workers unless there's been a significant exposure or you're working in a setting where there is significant exposure to TB. And part of the reason for that is this sort of intermittent positive, negative, positive, negative. I think for people with HIV, what we often do, and again, there's been no real effort to evaluate this in a clinical trial, but what we'll often do is use an alternative test if there's sort of this intermittent positive negative, and try to combine two different tests for latent TBI and TB infection in that setting. That's what I do in our patients with HIV. Although, again, there's not really a lot of evidence basis for that.
Great. Sticking on the latent TB topic, and someone who's got an okay or normal CD4 count and is asymptomatic, what are your thoughts about using 1 HP up front for 28 days and then starting ART after you're done with the 1 HP? Is that the strategy you'd use, or would you prefer to not do that?
It certainly was a strategy that was used in the clinical trial and didn't seem to be associated with adverse outcomes. But that was because the clinical trial was done at a time where the only available regimen that could be used for ART was efavirenz. And even in the clinical trial, the efavirenz PK data weren't available at the beginning of that trial. So yes, you could theoretically give 4 weeks of INH and rifapentine and then start ART. But in my practice, I don't see a reason to do that. I think dolutegravir is a very appropriate based regimen to use in the setting of 1 HP. And although there's some concern about twice daily dolutegravir in resource limited settings, that extra pill, does that affect your access to the regimen? There are studies underway looking at once daily dolutegravir, and I think those data are going to be borne out even with 1 HP. So I think many of my fellow practitioners in areas outside of the US use a once daily dolutegravir regimen together with 1 HP.
The next question has to do with secondary prophylaxis. We're used to using secondary prophylaxis, for example, in MAI, where until there's immunoconstitution, we will treat the disease and give secondary prophylaxis. What about for HIV TB? Do you ever give secondary prophylaxis after you treat a person with HIV for their TB? And if so, what would you use?
The only studies that I'm aware of have been done outside of the US in areas where there's a high endemic background rate of TB. And the one I'm most familiar with was done in sub-Saharan Africa, where country rates were higher than, you know, 900 cases per 100,000 population. And there are a couple of studies that suggest you could reduce the rate. The problem is that with such a high background rate of endemic TB, do you continue it forever? There's a fairly high rate of reinfection following treatment of TB. And so at this point in time, most experts do not recommend giving giving TB therapy in a preventive way after completion of TB treatment. And certainly in a low background region or a low endemic region like the US, you wouldn't do that.
Great. This is a good question. You mentioned that if you have someone with HIV and tuberculosis, you typically start TB therapy and then come in with HIV therapy a couple weeks later. What do you do in someone who's already on ART and then you diagnose TB? How do you manage that where they're on ART and then develop TB?
Yeah, it depends on what the ART regimen is. As you saw from the data in a rifampin-based TB regimen, the only real ART regimens that can be used are dolutegravir or efavirenz. Ritonavir-boosted PIs, with the exception of darunavir-boosted PIs, can also be used. But if someone's already on a bictegravir-containing regimen, I would switch to dolutegravir. If they are already on dolutegravir, I would continue their therapy. Obviously, what you want to make sure is that they're virologically suppressed. And virologic suppression has been associated with better TB outcomes and better overall survival outcomes in people who are being treated for TB. So that's the first thing I would make sure. And then if you can optimize the antiretroviral therapy, you would do that. Things were a lot more complicated before we started developing some of the INSTI regimens. So drug-drug interactions are relatively minimal if you're going to use an INSTI regimen. So,
any nuance around children? Similar question, but now on children, same strategy. You optimize the ART and treat the TB.
Yes. Yeah, I specifically avoided talking about children because there's a lot of caveats with weight-based therapy and things that you have that are cautionary notes with the fluoroquinolones and some of the other approaches that we would normally use in adults, but you might use with caution in children. But treating childhood TB, that's a whole different lecture, frankly. If we had another half hour, we could do that.
Some other day. To enough for alafenamide, TAF, and rifampin, are you now comfortable using TAF and rifampin together?
Yeah, early on, it was not recommended. There was a drug-drug interaction between TAF and rifampin that suggested that TAF levels were lower. The important point here is that the intracellular levels were not affected, and currently TAF can be used equally favorably with a rifampin-based TB regimen.
Perfect. When you're screening for latent TB, any preference about the T-spot TB versus quantiferon? It sounded like the predictive value was best for the T-spot, but is that where your default is?
Yeah, that study was very interesting. I was part of that study at one of the sites, and the positive predictive value was better with the T-spot TB test. Negative predictive value was the same, as was sensitivity and specificity, pretty similar between the quantiferon in-tube. There is a next generation quantiferon one that has been directly compared with T-spot TB, but not substantially in people with HIV. I think you could use the current generation of quantiferon assays, and if you're really concerned, you could use the T-spot TB. I guess it mostly depends on what's available to you in your own setting.
I think we're really at the end of the time, but I want to thank everyone who sent in questions. I think we got to most of them. I apologize that we didn't get to every single one, but we got to most of them. Why don't we go ahead and put up the slides as we begin to conclude, and thank Dr. Benson for a really terrific talk. I thought I certainly learned a lot, and I hope you did as well. Here's again a reminder on how to claim CME, pharmacy, nursing credits, as well as the time frame for that. The next point I do want to stress, in fact, I'll underline this, as your feedback is incredibly important to us. So please do take the time to let us know how we did today. And let's go on to the next slide. Just a couple of upcoming attractions. There's a Going Antiviral, very cutely named podcast by Dr. Mike Sag. The episode that's up right now is featuring the new antiretroviral therapy guidelines that Dr. Benson mentioned a few times. So please take a listen. Next slide. Here's a couple of our upcoming programs. Care of older people with HIV with speakers from Cornell. Next slide. We're entering the winter. We're in the winter 2025, about to enter 2025 in a few weeks. And so please join us for the latest update on virus outbreaks in January 15th. Next slide. Don't forget that the CROI meeting this year is in beautiful San Francisco in March of 2025. A new conference on bacteriophages is going to be featured this coming October. This is the use of bacteriophages for treatment of human infectious diseases. Next slide. And last but not least, most importantly, thank you all for participating. I hope you had a enjoyable experience with today's presentation. Please join us in 2025 for another series of talks. And final thank you to Dr. Benson and the entire IAS-USA staff. Have a good year, everyone. Good holidays as well.
Thanks, everyone.
Bye-bye.